Hi and good day to our fellow viewers. I am Ahmad Karim Alif bin Ahmad Zafir, the group leader for Group 2. Today we will be explaining case study number 8, which is the BTS case. BTS, not that BTS, more of a senior citizen BTS, is a 55 years old man with height of 160 centimeters and body weight of 62 kilograms. He was admitted to the hospital 2 weeks ago due to severe car accident. He was unconscious and placed on total parenteral nutrition. 3 days ago, he developed a fever of 40 degrees Celsius and chills. His blood pressure of 102 per 70 mm of mercury had dropped more than 30 mm of mercury systolic. He was treated with broad-spectrum antibiotic. However, he remained febrile and his condition has worsened. The fundoscopic examination revealed abnormality on his left eye. The white blood cell count is currently 10,950 cells per millimeter cube. Other results include AST level of 89 unit per liter, ALT of 98 unit per liter, and serocreatinine of 100 micromole per liter. Invasive fungal infection was suspected. Blood culture results of BTS show positive Aspergillus species which is sensitive to amphotericin B, voriconazole, and Caspar fungi. Other than current condition, BTS is taking tablet warfarin for his atrial fibrillation. Firstly, we explain the mechanism of action of these three drugs, which is the amphotericin B, voriconazole, and Caspar fungi. It will be presented by Shafika and Nabila.
A very good day. My name is Nurul Shafika binti Faizal and I will explain about the mechanism of action for voriconazole and Caspar fungi. Let's start with voriconazole. Voriconazole will act by preventing the synthesis of ergosterol through inhibition of 14-alpha demethylase enzyme. As we can observe in the diagram, lenesterol will be converted into several compounds before forming ergosterol. One of the important mechanisms in the ergosterol synthesis is the insertion of activated oxygen into the 14-alpha methyl group of the lenesterol. However, in the presence of voriconazole, this oxygen atom that normally bonded to the heme ion of the cytochrome P450 enzyme is replaced by the nitrogen atom of the voriconazole. Thus, demethylation of the lenesterol will be blocked and biosynthesis of ergosterol is inhibited. The depletion of ergosterol level in the cell membrane will increase the membrane permeability and disrupt cell function, and eventually the fungal cell growth will be inhibited. Let's move on to the mechanism of action for Caspar fungi. Caspar fungi will act by preventing the synthesis of beta-1,3-D-glucan through inhibition of beta-1,3-D-glucan synthase. As we can see in this picture, Caspar fungi will bind to the catalytic subunit of this enzyme and inhibit the polymerization of the UDP glucose. This will result in the inhibition of glucan chain synthesis. Caspar fungi can act as either fungostatic or fungicidal. In the fungostatic effect, Caspar fungi will only act on the actively growing part of the cell. Meanwhile, fungicidal effect can be observed where reduction of the glucan content severely impacts the cell wall integrity. The fungal cell wall will experience imbalance of intracellular osmotic pressure and which eventually leads to the cell lysis. That's all from me. I will pass my presentation to the next presenter.
My name is Nur Nabila binti Zainuddin. I'm going to present about the mechanism of action of amphotericin B. Amphotericin B is a type of polyene antifungals which has two different mechanisms of action, in which both will induce the membrane permeability of susceptible fungi. The primary mechanism of action of amphotericin B is through the binding to ergosterol. Based on the chemical structure of this drug, amphotericin B is amphipathic in nature, which means it consists of both hydrophobic and hydrophilic regions. The hydrophobic site of amphotericin B will face the hydrophobic interior of the membrane. This leads to the formation of a transmembrane ion channel in the lipid bilayer. and consequently allows the movement of ions from one side of the membrane to the other. The leakage of intracellular components eventually leads to cell death due to deprivation of essential cell constituents. Amphotericin B is also able to form toxic free radicals, which has a high chemical reactivity. The cascade of oxidative reactions will then lead to destruction of cell membrane, but the exact mechanism of this reaction still remain unknown. For question number 2, state which of the mentioned antifungal drugs is fungistatic and which is fungicidal against Aspergillus species. Voriconazole and amphotericin B are fungicidal, while caspofungin is fungistatic towards Aspergillus species. The presentation will be continued with the next presenter.
Thank you, Shafika and Nabila. Now, I will explain the potential drug-drug interactions involving the antifungal drugs above, which are amphotericin B, caspofungin, and voriconazole with the help of structural diagrams where it is applicable. First of all, amphotericin B formulations interacts with other medicines primarily by reducing their renal elimination or producing additive toxicities which may enhance the risk of kidney injury and electrolyte disturbance. Amphotericin B are not metabolized by hepatic cytochrome P450 enzymes. Thus, the drug interactions of amphotericin B with other drugs are mainly related to the side effects of the drug itself, which are nephrotoxicity and also electrolyte disturbance. The concurrent administration of amphotericin B with other drugs of similar effects may worsen the condition of the patient. The example of drugs that may interact with amphotericin B are antineoplastic agents, immunosuppressants, and also corticosteroids and corticotropin, which are also known as ACTH. The co-administration of amphotericin B and warfarin may increase the serum concentration in the body of the patient. Next, caspofungin are transported into hepatocytes by OATP1B1 transporter. Caspofungin are echinocandin drugs that have the lowest propensity to interact with other medicines and also other drugs. This is because caspofungin does not depend on the cytochrome P450 system, and it also does not influence the P-glycoprotein family. Thus, this is why caspofungin have very few known drug interaction with other drugs. The most common interaction of caspofungin is with rifampin and phenytoin, which may induce the clearance of caspofungin. Caspofungin has the most serious drug interaction with cyclosporin, elusadolin, and also Saccharomyces boulardii. Caspofungin are also found to have mild interaction with immunosuppressants. However, the co-administration of caspofungin with warfarin showed no effect on the International Normalized Ratio (INR), and thus it is proven that the co-administration of caspofungin with warfarin is safe. That is all from me. Sim Wei Ching will be explaining about the drug interactions of voriconazole with other drugs. Thank you.
Good day to Dr. and fellow friends, and thank you to Yan Wei for explaining the potential drug-drug interactions of amphotericin B and caspofungin. My name is Sim Wei Ching, and now I will continue to explain the potential drug-drug interactions of another antifungal drug, which is voriconazole. Firstly, voriconazole is the substrate and inhibitors of the hepatic cytochrome P450 metabolic enzymes, which are cytochrome P3A4, cytochrome P2C19, and also cytochrome P2C9, which will make it prone to the drug-drug interactions. This is most probably due to the drug structure of the voriconazole, in which the nitrogen atom in the triazole group will bind to the heme ion of the enzyme-bound cytochrome P450, while the fluorine substrate and also the hydroxyl group will also contribute to the drug-drug interactions. Besides, voriconazole will interact with the warfarin, which is a type of anticoagulant drug used for atrial fibrillation in this case study, due to the metabolism of S-warfarin by cytochrome P2C9. The cytochrome P2C9 inhibition will double the concentration of S-warfarin. Therefore, the co-administration of the voriconazole and warfarin will prolong the prothrombin time. the prothrombin time is a test to measure the time period used for the blood clotting. At the high prothrombin time usually means that there is a serious liver damage or cirrhosis happen in the patients due to drug-drug interactions. Hence, adjustment of warfarin dosage may be needed if both drugs are prescribed together in the patient. That's all from me, and the presentation will continue by my teammates to describe the safety of this drug in the patient with liver or renal dysfunction and also vision problem. Thank you.
Hi, I am Amy Yasmin Shahirah binti Muhammad Adha. Now, I want to talk about the safety of amphotericin B to the patient with renal dysfunction, liver dysfunction, and also vision problem. Amphotericin B is an antifungal medication that is used to treat serious fungal infection caused by Aspergillus species. It is given by injection into a vein. Amphotericin B should be given to patients who have potentially life-threatening fungal infection, but not to treat less serious fungal infection because it can cause serious side effects. Amphotericin B can induce nephrotoxicity. It can cause renal tubular acidosis, impaired renal concentrating ability, and also electrolyte abnormalities. Amphotericin B also can cause direct damage to the distal tubular membrane, which will lead to the loss of sodium, potassium, and also magnesium ions. So, patients who have a renal dysfunction should avoid amphotericin B, but if amphotericin B is necessary, dosage adjustment must be done. Amphotericin B also can cause liver dysfunction, but it is not a typical effect of amphotericin B. Appearance of liver dysfunction to patients who receive amphotericin B is rare, but there's also patients who got this disease after receiving amphotericin B, but it is not clear whether the disease comes from the medication or the patient itself is in critical condition. After that, vision problem is one of the rare side effects if patients receive amphotericin B. There's a small amount of drugs found in the cerebrospinal fluid, amniotic fluid, or vitreous humor. Blurred vision is one of the rare side effects if patients receive amphotericin B. So, if the patients have liver dysfunction or have vision problem, they should get advice from doctor first before receive amphotericin B. Thank you. Now, let's move on to my Shahira's part.
Thank you, Amy. Voriconazole. Voriconazole is extensively metabolized via hepatic cytochrome P450 isoenzyme CYP2C19 to the lesser extent by CYP2C9 and CYP3A4. Genetic polymorphism are common in the primary enzyme CYP2C19, which lead to either slow or rapid metabolism. Thus, the risk of hepatotoxicity increase in patients with slow metabolism of voriconazole due to the increase in drug concentration that is accumulated in the liver. Therefore, the use of the voriconazole is not recommended in patients with liver dysfunction. In contrast, renal dysfunction at any stage does not significantly influence the voriconazole pharmacokinetic. It is considered safe. However, patients who receive voriconazole may experience transient visual changes, including blurred vision, altered color perception, and photophobia. This may begin about half an hour after administration and last for another half hour. Uncommonly, transient visual hallucination also may occur. Next, Caspar. Caspofungin has adverse interaction in patients with liver dysfunction because caspofungin undergoes intensive enzymatic metabolism in the liver, which lead to the abnormalities in the liver enzyme. Thus, this may worsen the hepatic function. In the contrary, caspofungin does not significantly affect patients with renal dysfunction because this drug elimination is largely independent from the renal function. In addition, caspofungin only causes less common side effect to the eye, which is blood vision. Therefore, the use of the caspofungin is considered safe to the patient with existing renal dysfunction and vision problem. That's all from me. Next, Lau Mintai will explain about 8 general steps of selecting microbial.
Thank you, Amy and Shakira. My name is Lau Ming Tat. I will be presenting the first 4 steps of the general steps to select an antimicrobial. The first step is know the possible causative agent. BTS has fever, low blood pressure, and chill, which indicates the presence of infection. At first, invasive fungal infection was suspected. It was later confirmed after having a blood culture. The blood culture shows the presence of Aspergillus species. The second step is to list suitable antimicrobial that are active against the possible causative agent. Aspergillus species is an opportunistic fungi, and the antifungal that are active against the Aspergillus species are the amphotericin B, Voriconazole, and Caspar. The third step is to assess the patient and current condition. BTS is a 55 years old adult male. He is assumed to have no allergy as no information is provided. He is unconscious and is placed on total parenteral nutrition. His body mass index is 24.22, indicating that he is not obese. After calculating his creatinine clearance value using Crop-Galt equation, he is found to have renal dysfunction. His calculated value is 64.70 milliliters per minute, which is not in the range for a healthy man, which is 97 to 137 milliliters per minute. Besides, his AST and ALT values are 89 and 98 units per liter respectively. These abnormal values are out of range of normal AST and ALT values, which are 5 to 40 units per liter and 7 to 56 units per liter. Therefore, this indicates that BTS has liver dysfunction. Next, fundoscopy examination revealed abnormality in his left eye. As a result, drugs that will cause visual disturbance should be avoided. Lastly, BTS is taking warfarin to treat his atrial fibrillation. Therefore, drugs with the risk of interacting with warfarin should not be administered. The fourth step is to list adverse effects or toxicities of the identified antifungal agents. The most serious adverse effects of amphotericin B is nephrotoxicity. Besides, it can cause hematological toxicity, which are pneumocytic anemia and thrombocytopenia. Infusion-related reactions, which include fever, rigors, headache, nausea, vomiting, and hypertension, may also occur. Serious neurotoxicity and serious allergic reactions are rare, but there have been cases where these adverse effects are reported. The common adverse effects of voriconazole is visual disturbance. Examples of visual disturbance include ocular discomfort, altered color perception, photophobia, and decrease in vision. Besides, voriconazole is able to penetrate into the CNS, therefore it has the adverse effect of causing reversible neurologic symptoms such as visual hallucination and vivid dreams. Voriconazole also exhibits hepatotoxicity and nephrotoxicity. Lastly, voriconazole is a cytochrome P450 enzyme inhibitor. Co-administration of voriconazole with warfarin will increase the concentration of warfarin in blood serum, leading to toxicity. Caspofungin is generally well tolerated. One of the adverse effects is abnormal LFT's value will be observed. Other common adverse effects include pain at injection site, phlebitis, gastrointestinal disturbance, rash and hypersensitivity reactions. Hematologic effects, seizures, psychotic disturbances, and malaise are uncommon, but there have been cases where these adverse effects are reported. That's all from me. Next, my friend Ahmad Qayyum will continue to present the remaining 4 steps.
Thank you Mingtat for explaining the first 4 steps. Step 5 is list pharmacokinetic properties of identified antifungal agents. For amphotericin B, it is very lowly absorbed, therefore it is not given orally. It is given through IV infusion for high bioavailability. It is widely distributed as it is highly plasma protein bounded, up to 98%, and it is extensively distributed to the tissues. It is metabolized in the kidney, and its half-life in the tissues are up to 15 days and in the plasma is 5 days. It is excreted via bile and urine. 2% to 5% of the given dose can be found in the urine within 24 hours. For voriconazole, it is highly absorbed if given orally, as it has rapid absorption. Therefore, it can be given in oral form or IV infusion. It is widely distributed in both intracellular and extracellular compartment, and it is protein bounded up to 60%. It is metabolized by the kidney by the CYP2C19 enzyme, and its half-life is 6 to 8 hours. It is excreted via urine, where 2% of the whole drug and 80% of the metabolite can be found there. For caspofungin, it has also low absorption, therefore it can be only given through IV infusion. It is also highly distributed as high protein binding of 98%. It is widely and well distributed through the tissues, but it cannot penetrate the central nervous system. It is metabolized in the liver by first undergoes spontaneous disintegration, and then peptide hydrolysis, and finally N-acetylation. Its half-life is 9 to 11 hours. It is excreted through urine and feces, where 41% can be found in the urine and 31% can be found in the feces. Step 6 is determine the most suitable route of administration of antimicrobial agent. As been said by the previous presenters, the patient is unconscious and his condition has worsened. Therefore, it needs a fast-acting drug and high bioavailability. Therefore, it is recommended to give the drug via IV infusion. Step 7 is determine the antifungal dosing. For a standard amphotericin B, which is amphotericin B deoxycholate for IV infusion, it is given 0.7 to 1 mg per kilogram per day. However, due to its nephrotoxicity, it is recommended to give alternative drug if the patient has renal impairment. For voriconazole, a standard voriconazole for injection, which is Vifen, it is given firstly 6 mg per kilogram twice daily, then 4 mg per kilogram twice daily. However, it is avoided if patient have creatinine clearance less than 50 ml per minute, and also patient with hepatic impairment, the dose is reduced by 55%. For caspofungin, a standard caspofungin, which is caspofungin acetate for injection, candidus, 70 mg on day 1 is given, then 50 mg once daily. For moderate hepatic impairment patients, it is adjusted to 35 mg once daily. The last step is step 8, which is select the most appropriate antifungal agent. We chose caspofungin, and here's why. For amphotericin B, although it has high efficacy, especially in its liposomal form, and it has fungicidal activity towards Aspergillus species, due to its high nephrotoxicity, it is not recommended to give BTS, as BTS has already suffered renal impairment in the first place. And liposomal form of amphotericin B is way more expensive than other alternatives. For voriconazole, although it has lower toxicity compared to others, as his half-life has the shortest one, and it is fungicidal towards Aspergillus species, Due to its serious effect on the eye and interaction with warfarin, warfarin will reduce its efficacy, therefore it is not recommended to give voriconazole. Lastly, caspofungin. Caspofungin is the recommended drug, as first, it has similar efficacy to the liposomal amphotericin B, and it has phagocytic activity towards Aspergillus species. It is more tolerant and has lower adverse effect, and the therapeutic efficacy of warfarin is increased when combined with caspofungin. Therefore, we chose caspofungin as our drug. Later, Siqian and Binghe will explain the monitoring plan for BTS. Thank you.
Thanks, Kayum, and I would like to discuss question 6. First, the parameter to indicate effective treatment is the temperature. The body temperature of BTS increased due to high fever, so his body temperature is checked every 4 to 6 hours. The monitoring goal is achieved when the temperature reduces to normal and the fever subsides. Second, blood culture. Based on the case study, the blood culture shows the growth of fungi. Thus, the blood sampling is repeated after 36 to 48 hours of post-therapy. No growth of microorganisms in the culture if the therapy is effective. First, the common side effect of the drug is abnormal LFTs. The liver function tests are carried out to determine the liver enzyme levels, which are AST and ALT values. No elevation of initial liver enzyme levels if the treatment is safe. The drug is stopped if the liver enzyme level elevates drastically. Second, gastrointestinal disturbance. Gastrointestinal distress, such as diarrhea and weight loss, is monitored regularly. There's no gastrointestinal disturbance occur when the therapy goal is achieved. Third, irritation at the injection site. The injection site is observed every morning. The treatment is safe when no irritation happens at the injection site. Fourth, skin rashes and hypersensitivity reactions. The development of rashes or hypersensitivity reactions are observed daily. Zero development of rashes and hypersensitivity reaction indicates the therapy is safe. Fifth, phlebitis. The sign and symptoms of phlebitis like redness, swelling, and tenderness in the skin are monitored. The safety of the treatment is ensured when no sign and symptom of phlebitis arise. That's all for me. I would like to invite Binghe to continue discussing question 6. Thank you.
Thank you, Siqian, for explaining the monitoring plan for efficacy and safety aspect. I'm Binghe, and I will further explain the monitoring plan for potential interaction with caspofungin. First, when caspofungin is given together with tacrolimus, it will decrease the concentration of tacrolimus by 20 to 25% and increase the risk of organ transplant failure. So, blood test is carried out to monitor the concentration of tacrolimus. Our monitoring goal is the concentration of tacrolimus should be in the therapeutic range. Next, caspofungin will interact with cyclosporine. Cyclosporine will decrease the body's ability to process caspofungin, which leads to accumulation of caspofungin in the body. As a result, this can cause liver damage. To monitor this condition, liver function tests are carried out to monitor the AST and ALT values. Our monitoring goal is the AST and ALT values should be in the normal range. AST value should be 5 to 40 units per liter of serum, while the ALT value should be 7 to 56 units per liter of serum. Another example is the caspofungin will interact with rifampicin. Rifampicin is an inducer of hepatic SIP enzyme. The drug-drug interaction will increase the metabolism of caspofungin, which causes reduction of caspofungin in the plasma concentration. As a result, low amount of caspofungin
cannot exert an antifungal effect. To monitor this condition, blood culture is carried out to test the effectiveness of caspofungin as an antifungal drug. Our monitoring goal is there is minimal growth of fungi, which indicates that the antifungal drug, which is caspofungin, exerts a good effect towards the fungal infection. In the next part, I will further explain the patient counseling information of Etraconazole. That's all from me. Thank you.
Thank you, Binghi. In question 7, I will explain about the counseling points on how to administer Etraconazole in both pharmacology and chemistry part. First, consume Etraconazole capsule or tablet immediately after a meal. The presence of meal will increase the gastric acidity level. Gastric acidity is important for the drug to solubilize, thus providing an optimal absorption of the Etraconazole in the gastrointestinal tract. Second, swallow the whole capsule of Etraconazole. Do not crush, chew or break it. It is because Etraconazole has poor dissolution in the gastrointestinal tract even though its membrane permeability is high. So capsules are designed to release this Etraconazole slowly into the body over time. Crushing them will cause the active ingredients to be released at once, thus resulting in the overdose of the drug. Third, consume Etraconazole with an acidic drink if possible, such as non-diet cola. It is because acidic drink will reduce the stomach pH. Low stomach pH is important for the Etraconazole to solubilize, thus providing a maximum absorption of the Etraconazole in our body. Fourth, take Etraconazole at evenly spaced intervals every day. It is to ensure a constant level of the drugs in our body. So the therapeutic effects of the Etraconazole is optimized. That's all from me. Thank you. Next, Kurniati will explain the next part of the counseling points.
Thank you, Ain. Now I'm going to continue on the next points for patient counseling. Patients should continue taking the full prescribed drug even if they are feeling well or the symptoms have disappeared. Inadequate period of Etraconazole treatment may lead to the recurrence of the infection. We do not want this to happen, so patient should be advised to finish his drug regimen. Besides that, any drug-drug interaction with Etraconazole should be taken into account. Since BTS is also taking warfarin, proper dose adjustment and more frequent monitoring are needed. This is due to both Etraconazole and warfarin are extensively metabolized in the liver. Hence, addition of Etraconazole may increase the hepatic toxicity and blood levels of warfarin. Apart from that, the patient should avoid taking Etraconazole with potent enzyme inducers of CYP3A4 such as isoniazide, rifampicin, and carbamazepine. Etraconazole is mainly metabolized by the CYP3A4 enzyme, so the potent enzyme inducers of CYP3A4 drug may decrease the bioavailability of the Etraconazole and reduce its efficacy. And last but not least, patients should be advised with proper storage of the medicine. The capsule should be stored at room temperature and protected from light. This is because the active ingredient may degrade when in contact with light and moisture, thus causing the potency loss, altered efficacy, and adverse biological effects. Photoproducts of this drug also may be harmful and cause phototoxic, photoallergic, or photosensitization reactions upon administration. That is all for case study 8 from Group 2. We hope BTS would have a speedy recovery soon. Should you have any question or constructive feedback and suggestion, please comment down below and be sure to give this video a thumbs up.